Thank you for coming. So I'm Alistair Cartwright. I'm Director of what's called Informatics, health work for IT and technology across the Health Commissioners in Leeds. I'm also Director of something called the Leeds Digital Technology Programme, which again is about health and care. I did have half an hour ago a jacket, no jacket sort of debate. I went no jacket, but obviously went outside with no jacket, so I'm just warming up. So that's good. So who have you got in the room? So you've got myself. So I'm a health technology specialist. Julie Oxley, who's going to be speaking, is a care technology specialist. I didn't mean to have to read it, Julie. And then we've got Alex Stevens, who is a social worker, a practitioner. We just thought it was really good to get somebody in that actually uses some of the technology. We've got other experts in the room, so Colin Mawiney. Oh, I thought he'd left with the virus. So Colin is the city's lead on innovation for health and care, also the city's lead for inward investment. So in terms of relationships with SMEs, companies, tech specialists, etc., Colin's job is around trying to make sure that that has a voice in the city. We've got Tony and Phil from the Ripple Foundation. I can see Tony. Oh, no, I can see. So we've got experts in the room. Right. So this is a lifting the lid session, and the idea is it's lifting the lid on. If you are a citizen of Leeds, so hopefully a citizen of somewhere that has digital, what are some of the things we're doing with your taxpayers' money to make sure you have facilities to improve your health and care? Also, we acknowledge we need to work closer, smarter with the digital sector. So it's almost just saying, let's demystify some of the stuff we're doing in Leeds so we can start dialogues, so we can use spaces like this as a course of travel, which is, becoming well established in Leeds. Okay, so we're looking at something called our blueprint. We'll be summarising some of our headline initiatives. We could talk for days on the stuff that's going on. We're having to constrain it to a short space of time. We are going to try and explain some of the jargon. Real life benefits, important. We'll take questions. We hope we can answer some questions. If we can't answer them, we're really keen to sort of set up links for follow-up, etc. And it is, please feel free to interrupt. The fact that I've not got my jacket on shows that it's all touchy-feely this morning. Right, so first observation is health and care is really complicated. So for those that don't work in the sector, these are all separate statutory organisations with money coming in, with budgets having to be balanced, employing staff, having legal responsibilities. I might have a point of it. So we've got secondary care, mental health, we've got community, we've got the ambulance, we've got something called public health, adult social care. So it's a challenge because this is a complex system. And if you were just to take one of those sectors, so just remember, each complex system has its own set of digital. So if you were just to take secondary care, jargon busting, secondary care basically means hospitals, but hospitals that deal with non-mental health, non-community, etc. They also have, within them, separate departments that all, if we're unlucky, have, if we're lucky, have systems. If we're unlucky, have separate systems. If we're even luckier, have joined up systems. So what have we got here? You'd have a system for maternity, a system for A&E, a system that looks after pharmacy, a system that looks after radiology. So you can see there is a challenge. The challenge is joining up. And therefore, there's Bob. Could be anybody. Bob S, if we go for a female gender. But do we see Bob as a person? Could be my mum, could be my uncle. The health sector, if we're not careful, sees them as separate bits. So what have we got? Glasses, ophthalmology, heart, cardiology, doctors in the room, help me, walking stick, orthopaedics, etc. So the challenge is, if we are to deliver integrated healthcare, we need to think about individuals, not component parts. So, yes, technology has a significant role to play. However, as you'd expect, yes, violin time, the public sector is trying to use its resources as effectively as possible. There are very few new sources of funding within the NHS or social care. Therefore, what is our opportunity? Well, our opportunity is working together as the jargon word is place. So Leeds is the place that we believe if we work smarter, we can deliver integrated technology for the good of health and care. And this is our very basic strategy. And the reason it's so basic is, we think fairly simple, but it helps us have common dialogues, it helps us put things in. I know I've said we don't like boxes, but certain boxes are helpful. Right. The idea is, if we can form systems that are valuable to the professionals looking after citizens and patients, brilliant, that's excellent. If we can also look at digital for the citizens of the city, that's also great. So the professionals is, I need to care for these individuals, and they're visiting a hospital, they're in a community clinic, etc. The citizens is about, I need to care for myself more and more. Hopefully, I'm preventing becoming ill. If I am ill, I want to be self-managing, in conducting self-care. The bit in the middle is, as a city, one of the strengths of Leeds is our communities, our localities. So our strategy is, yeah, great for loads of individual information at that side and individual information at that side, but if we knew more or know more about our communities in the city, that's really powerful. So if I live in an area, let's just take an area, if I live in an area, Armley, let's say that, what are the transport links like? What's the air quality like? Where are the assets? Where are the gyms, the gardening clubs, the sports centres, the swimming pools, etc.? So we're really encouraging that middle layer of open data, which is, let's share data about our place. And if you live in a place, hopefully, you will be able to benefit from all of these things. So on top of that, we're really keen to use technology in a utility fashion. So all those separate organisations will all buy PCs, laptops, have Wi-Fi from different companies. You go into a building, you think, oh dear, you see something on the ceiling, but I can't connect to it, etc., etc. So we're really keen to start looking at technology where we can as a white good, a utility. Really keen across the piece to link together professionals, citizens, and an event like today is about partner engagement. Governance is really important. So as you can imagine, health and care, you don't just leave the way you do healthcare to chance. There's lots of governance, whether it's how we use information, how we share it, how clinically it is used and useful. And integration. Integration is a massive part of our piece here. And then two little subsections on the professionals. Again, systems for professionals. All those boxes, there weren't boxes, there were circles, we are trying to integrate. Now if you integrate things, you tend to work faster. So I can do this faster than I did yesterday, more accurately. But actually the next layer is, how do we work smarter? So where can we look at things like intelligence that we add, that digital adds? And then the sort of final layer of our very simple picture is business intelligence, the analytics that helps us understand what's going on in our city, with our patients, with our citizens. That's the more complex version. The slides will be shared. It's a diagram that most of us now in the professions, in the digital profession, in the sector, recognise that diagram. It tells us a story. I'm colourblind, so I think there's I won't even try to guess the colours. Lots of colours, they mean something. For those looking in black and white, they don't mean a lot at all. Right. And then this is one of our strap lines. We are very keen to simplify, we are very keen to standardise, and we're very keen to share. So if we can make something simple, if we can work to a standard, and that's a lot of the work Phil and Tony are doing with the Ripple Foundation, and if we can share it for the good of the NHS, for the good of the citizen, why wouldn't we? So very much almost in this, yeah, I'm sure there is IP and intellectual property and all this, but our philosophy is, if we create it, let's share it for the good of the citizen in Leeds. Again, we'll share the slides. I don't expect you to copy down that reference or that link there. But we have expressed this about 10 months ago in something called the Digital Roadmap. It's online. It uses some of the language that I've just described. You'll get it with the slides. I'm just letting people take photographs. I think you've got my best side. She's in the back. Right. Okay, just glossary of terms then. This is just a very feeble attempt at saying we speak in a lot of jargon. A lot of jargon is not helpful. I know there's a lot of digital jargon, and again, the interface between technology, clinicians, doctors, care professionals, business sector is really important, and that's been why we presented our blueprint in very easy to read language. Anybody have a stab at any of those things?
CIS is, well, isn't it? I was going to say it's Calderdale Information System, but it's not Calderdale.
It's pretty, well, it is in conjunction with Calderdale. We call it Client Information System. So just again, a little bit of jargon. In the health service, the Bobs are called patients. In social care, they're called clients. So again, language. Okay.
System and EMIS web patient data records for GP.
Yeah. So system 1 up there. Every GP practice in Leeds, of which there are 106, of which there are about 150 branches, because some of them main branch, use either colourblind. I can't see a red dot. System 1 or EMIS. So they're both clinical. I have got explanations that I'll put on 2 seconds. I was just making it feel painful, like a guest. E-referral service, ERS, great.
Electronic discharge advice, is it?
EDAN, electronic discharge advice note. That's what, if you've been in hospital, they write something up about what's happened to you electronically, it goes to your GP. I'm going to put the answers on. Integrated neighbourhood teams are really important in Leeds. Again, thinking about the strength of localities or places. The idea is, let's use those places, Beeston, Morley, Chapel Allerton, Roundhay, wherever it might be, and because one of our key clinical aims is to keep people out of hospital. Not if they need to be in hospital, but people generally don't want to be in hospital, they don't choose to be in hospital, so if we can care for them out of hospital, that's a good thing. And integrated neighbourhood teams are a set of professionals, usually wrapped around a GP practice or GP practices, so district nurses, social workers, GPs that are trying to look after patients to prevent them from getting into hospital. Okay.
What's AQP?
Yes, you can.
Oh, well spotted. AQP, yeah. Yeah, I just missed that. So, the health service, you know how complicated we said it was? It's even more complicated. There are things called any qualified providers, which basically means, so if, let's take the example, if I've got a mark on my skin and go to the GP, I would generally go to a dermatology service in hospital. What we've now agreed is, actually, once you're in, is that the best place to be? Well, it might be, but actually, other approved clinical agencies, it could be a GP practice, could provide a dermatology service. So again, GP practice, normally come in, have a consultation, but are now doing dermatology, which is a bit more specialist. They need to think about digital. What's the consequence of that? Okay. How am I doing for time?
You have 6 minutes, ideally.
Okay. I can slow down because this is my last slide. There you go. Couple of other things, just to, on there is something called PSN and HSCN. This is a renewal, well, at the moment, more jargon, every NHS organisation is connected, when I say together, they're connected to the cloud by something called N3, the NHS network. But actually, if you've got a building that's shared between the council, so the NHS has its cable in the corner, the council has its cable in the corner, we are procuring a network, a physical network, that will be 1 point, but allow health and local authority to use it. And it's not just local authority, it's the public sector. So the idea is, in Leeds, in public buildings, could we set up an any place, anytime, anywhere facility, which basically means I'm an NHS employee, I go into a council building, but I can sit there, log on, etc. So that's a really big strategic piece of work. Okay, I think, well, that's in the final seconds. Anybody, anything you wanted to query? That's almost the landscape of what we are doing in Leeds. No.
Oh,
Please, yeah.
It sounds very good.